All right, thank you for staying with the Monday Report. The town hall conversation starts right now, just hours before Kenya joins the world in marking World Asthma Day. The theme this year is Asthma Education Empowers, and will allow you to ask all the questions the experts with me here, and also our audience will be given a chance to ask all the questions they may have. You can also pose your questions online at Trevor Mbija at Citizen TV Kenya. Use the hashtag Monday Report. Let me start by introducing my guests from my immediate left, and we have Dr. Juma Bwika, President, Respiratory Society of Kenya. Thank you so much for making time. Joanne Kagema is here. She's a respiratory nurse, Kenyatta National Hospital. Asante sana for making time. We have Dr. Adil Waris, a consultant pediatrician and pulmonologist at Aga Khan University Hospital. Thank you so much for making time. And last but not least, Dr. Dorothy Ayuak, Deputy Chief Pharmacist at the Kenyatta National Hospital. Asante sana for making time. And Dr. Juma, I'll start with you on this. What is asthma?
Thank you very much for that question. So asthma is a chronic condition. That means it's one that is incurable and it endures through life. And it results from inflammation inside the air passages within the lungs. And this causes limitation in flow of air when we breathe. And this results in episodic symptoms that come and go depending on the triggers. And these symptoms include a cough, wheeze, chest tightness or chest congestion, and breathlessness on exertion.
Yeah. How many people are affected by asthma here in Kenya?
So we expect, or we estimate that about 7.5% of Kenyans live with asthma. That is about 4 million Kenyans. And globally, there are about 330 million people anytime who have asthma or who live with asthma, that is a lot of disease really. If you go to any country, between 1 and 29% of the population of that country will be having asthma, and it depends on what sort of genetics, what sort of air quality they have in that country, urbanization and industrialization and the rest of it.
Interesting. Joanne, I'll come to you in just a bit, but let me bring in Dr. Dill first on this. How does asthma present in children?
Trevor, if a parent is listening to me right now and this parent says, oh my goodness, my child tends to cough very frequently. You know, we're used to our Kenyan children having the homa every 2 to 3 months. You'll have a bit of a runny nose, you'll have a bit of a cough in 3-4 days, everything is settled, a little bit of fever. Now asthma doesn't do that. Asthma in children, now the cough stays for a little bit longer than that. For the traditional parent will turn on and say, you know what, Trevor, my child has now been coughing for almost 14 to 20 days. The cough is more at night. The fevers are very mild, very gentle. And what I find very strange is that when my child runs and plays, my child starts coughing. And you know, we have this Kenyan thing where we say that, oh, my child has run and played so much, amecheza sana mpaka ameanza kukohoa. You know, that statement is not true. I always tell people, when you see Ronaldo playing soccer, you see Messi playing soccer, you see our beautiful Kenyan runners crossing the finishing lines, they're not coughing across the finishing line. So when your child is coughing, when your child is running and playing, and it is a routine and a habitual thing, beware, this could be one of the telltale signs of asthma.
Yeah, that's an interesting way to put it, because it's true that most Kenyans just ignore it. In fact, they say it's normal for kids to have that cough. So how then do you diagnose asthma in children then? You said 14 to 20 days. If it goes beyond that, is that the only telltale sign?
You know, so that's like sign number one, that, you know what, my child is getting very frequent coughs and colds. So we are used to our children 0 to 6 years of age getting a cough and a cold every 2 to 3 months. So that's normal. But are you getting it every month? Is it staying for very long? Is your child coughing also when your child runs and plays? Dr. Juma Bwika will tell you that in adult medicine, I am a pediatrician, in adult medicine they can do some lung function tests. We have some of these peak flow gadgets over here that's easier in adults. In pediatrics, a little bit harder than that. So number one, do you have a history that sounds like asthma? Then you go to your general pediatrician, or you go to your doctor, he listens to the chest of your child, he says, hold on a second, this child is itching your eyes, is having a rubby, itchy nose, is sneezing very frequently. They will listen to the chest and they say, oh, your child is wheezing. So now that will now be a telltale sign. In fact, there are even parents out there who will tell you that I can actually hear the wheeze in my child. So we also say that not every asthmatic is wheezing, and not all children who wheeze have asthma. But you see, it's telltale signs. So you're coughing for 15 to 20 days, you're coughing when you run and play. You're getting these coughs and colds very frequently. Then you go to the doctor, he listens to the chest and you're wheezing. Now in pediatrics, that's one of the signs that yes, this child might have asthma.
Okay. We'll come into more details of that, but let me bring in Dr. Yuang on this. As a pharmacist, what then is the role of pharmacists when it comes to dealing with asthma care?
So besides ensuring that we have the medications that you require to be able to adequately control the asthma symptoms, because it's a chronic condition, so you need to make sure that access is key, availability, and then also educating the patient so that you can take them through their journey. They have received a diagnosis. Have they understood the symptoms, the triggers, when they have left the doctor or the healthcare provider that they are seeking? Have they understood the symptoms and the triggers, and that it's actually chronic? We are not expecting that when they finish one inhaler, that will be the end of it. And that also encouraging them to have personalized care plan. I think going forward, we're talking about action plans for the patient, but having personalized care plan and not to look at it as though it's like malaria, you know, you have a standard treatment, but for asthma, you manage according to your condition, and just appreciating that that will vary and will not be the same as probably another child in the family or another relative who has asthma, and also just empowering them, because we want them to be free-spirited, to be able to live their lives, to breathe easy as they just go about their activities. So giving them whatever ongoing support, and importantly also referring. We find a number of times patients want to go direct to the pharmacy and not pass the other healthcare providers.
Yes.
So referral is key when you identify an issue that needs to be handled by another healthcare provider.
Okay. Speaking of inhalers, let me now bring in Joanne on this. Joanne, I see you have some gadgets there. Would you kindly just show us the best way of dealing with this, the inhalers techniques? What is the best way of doing it? Assuming somebody has no idea what's happening, and I'll give you my cameraman some time to also focus as you show us what is the best way of doing it. And then Dr. Adil will show us how to do it for children.
Yeah. We have various types of inhalers that are in the market, and depending on what the patient has been prescribed on. This one is what we call a meter dose inhaler, or an MDI, and which is very common in the market. Now we have a tambohera, which is a dry powder inhaler. We have also a discus, also a dry powder inhaler. We have also a hard inhaler. So they have the same concept, but they are used differently. Mm-hmm. So for this one, it's very common that you need to shake it. Shake it,
so the first thing is to shake.
First, shake it.
Okay.
The first thing you shake it, and then you prime it when it is new. When it is new, you just remove it and prime it.
Okay.
And then after that, then you can coordinate breathing in and breathing out, and then you inhale for 10 seconds as it is in. Then you feel the effect of the medication. And then for the people that are not able to use the normal inhaler, we can always use it with a spacer. And you can use a spacer even in an adult. Mm-hmm. In an adult who is a very elderly and cannot have a respiratory effort, you can use a mask and a spacer, where you shake and then you put it in, and then you spray in, and then you breathe for 10 seconds.
Mm-hmm. Okay.
For anybody who is able to use the respirator, you can use it with a mouthpiece.
Okay.
For this one, you can give it not only for what you do for the children, but even for the people with a challenge, like people who have a stroke, the people who have a disability like a facial palsy. You can use it to the mask, because what you need is to ensure that the person has gotten the medication right to the airway to ensure that he is able to breathe. And then there is this one, that you hold it like that. You don't shake it. The MDI, you shake it. Mm-hmm. But for this one, you don't shake it. You just hold it like this, and then you open it like this, and then you twist, and then it gives you a creaking sound, and then you inhale it. So anybody who is using this one has got a respiratory effort. So you have a way that you are able to inhale for 10 seconds. Mm. And then once you finish, you wipe the mouthpiece, and then you close it for the next use. And then you have another dry, which is this one, that is also a dry powder. It's a discus. It's looking very beautiful and very nice. So nobody can know that you're using, because asthma comes with stigma. So you open it like this, and then you pull it down the lever, and then you inhale it for 10 seconds, and then you wipe it there. And every time that you're using the dry powder, or even some of the MDIs, you need to rinse the mouth with water, and then spit it.
Okay.
So that you can remove the powder that is in this rinsing, because of some of the effects that it can cause.
Yeah.
Either you can have candidiasis or thrush.
Yeah.
You can also have dysphonia, which is the hoarseness of the voice. So when you rinse it, you are able to clean up the system, and then later you can take the water.
Okay.
So that is how we use the devices. So different devices are used differently, but with the patient, depending on the patient that you are using, that is what it determines. Because for an elderly person may not be able to use a discus or a tabuera, but may be able to use the other MDI, a meter dose inhaler, with a spacer. So different categories of people use different ways with the spacers to ensure that you get the proper medication, that it goes and gets the effect into your airway. And then you continue educating the patient or the client on how to use it and how to clean it, because most of the time, because of the infection, we have to do the infection prevention control. So how you clean it, the mouthpiece, because the mouth has never been sterile. So you have to clean it, and then you keep it safe.
Okay.
Yeah.
Dr. Adil, that is in adults now, but Dr.
Yes.
Adil, how do you do it in children?
So I think all of us need to be very clear that when we are dealing with asthma, it's the problem of the pipes of the lungs. We call them trachea and bronchi and bronchioles. So we'll keep it simple and just say the pipes. And the medication that we need to give are inhalers, because the inhaler now goes to the pipes. So I'll demonstrate an adult technique for you to see how complicated this can be. And that's now a doctor showing it to you. So you have to shake, and it can be as simple as this. If you hold this device this way, the medicine stops coming out. And I tell you, Trevor, there are so many people out there who are just spraying this way down. It is this way. If it's not this way, you don't get the medicines out. Okay? So you have to shake. This is now for an adult.
Yeah.
Breathe out maximally. I'll just demonstrate, and then I'll speak about it.
Yeah.
Inhale and hold. And even as I inhaled, I don't know if you saw a little wisp that went up. That even indicated that I didn't do it perfectly. And if I am also making a small 5% mistake, can you imagine children? So because children are not going to be able to do the technique that I've just demonstrated, we shake, we insert it behind here. This is a little bit too small for me because I'm an adult, but my children will tell you I'm probably their age mate. So I put it here. So imagine it's fitting me now. I don't know if the cameraman will be able to focus on the valves there.
He's able to.
But I spray once, and then I breathe 10 times.
Okay.
So let me tell you 3 mistakes our Kenyans are making.
Yeah.
Mistake number 1, I'm a child. Spray. So I'm in a hurry. Yes, it needs to be deep and slow. Mistake number 2, our moms want to teach our children how to count. So you put the dawa here and you spray, and then the child decides that I'm going to have a conversation with Trevor. Trevor, you know what? I went and I saw you yesterday, and then, so you're supposed to be breathing silently and deeply.
So no talking.
And no talking. So deep breaths, and that's how you do it. So you shake, spray, and you breathe 10 times. If the doctor says you want a second puff, shake again, and repeat the cycle again.
At what intervals is this done, Dr. Adil?
So if the doctor says you want to do 2 puffs, so you'll do 1 and then breathe 10 times, and then you can wait like a couple of seconds, maybe 5-10 seconds, to give the child a bit of a breather. You know our children, Trevor, they're all over the place. You can't keep them here. So give them 5-10 seconds, and then bring them back, and then carry on with the next puff. So it's pretty much back to back. You don't have to wait too long before you do one to the other.
So is this twice in a day, once in a day?
So sometimes the doctor will say, sometimes the doctor will suggest that you take it once in a day. Most of the inhalers that we have to treat asthma are steroid inhalers. Okay, and most of the time they're given once in a day. There'll be times when the child or the adult is also a little bit sicker, and that you have to do it twice in a day. And you know, I've used the word steroid. And that will send a little tiny shiver down every parent who's listening to me right now. I want to reassure you, Trevor, that when we're talking about asthma care, be it for children and adults, this is now across the board for the panelists who are here today, a steroid inhaler is a safe medication. What the parents, sorry, I'll refer to parents most of the time, what they need to really be worried about is the syrups and the tablets of steroids that we are swallowing in our Kenyan community. Those are medicines like prednisone. Those are medicines that you need to try and avoid at all costs. If Dr. Buika gives it to you, that's fine, we understand, he's at his level, etc. But for the parent out there, I want you to know that when you're spraying a steroid inhaler, one puff, once in a day, you're giving 1/1,000 the amount of medication than if I took the pill. And that statement and that number, I'm not here to complicate life for the Kenyan listening to me right now, but we need to understand that when you're using a steroid inhaler, you're using microscopic amounts of steroid that only go to your chest. They do not go to the rest of your body, and so they do not cause side effects. And right now what is happening in Kenya is everyone is drinking the steroid, so we're having the steroid permeate our entire body. So now we're going to get diabetes and blood pressure problems and sugar levels. And the parent who fears steroids, that's the one you need to fear. The drinking, swallowing steroid. That's the one, Trevor. Don't go down that road.
Okay. Dr. Buika, how do you know and how then do you control asthma? Because it's interesting what Dr. Adil just said, that there's a steroid conversation is all in there. But how do you know? Like an ordinary person, how would you know?
Okay, so the hallmark of asthma is that symptoms come and go. And they're not permanent, they're not there. One could be having an attack today and could be running a marathon tomorrow or going up mountains. And when we meet patients, we want to know that they have good management. We want to know they have good control. So asthma control is about how well the symptoms are managed. We want that patients are not woken up in the night more than twice a week because of their asthma symptoms. That they're not limited in their activities of day-to-day life because of their symptoms. C, that they're not using their reliever medication to relieve the symptoms more than 2 times in a week. And they're not disabled by this asthma. You can quantify this and find out when they come to clinic. You just ask those 4 questions and see if you're not happy with the control, then you know the treatment dose, as Dr. Waris has said, that they are on is not enough, that they need to have more treatment. And when we say treatment, there are 2 types of treatment. There's that treatment that keeps asthma well controlled. We call that maintenance treatment. We also have reliever treatment. Reliever treatment is usually not necessarily targeted at the underlying disease process in the airways. It's meant to open up the airways so that people feel better immediately. So when people are using a lot of that, then it means they don't have good control.
Yeah, and you say this is incurable.
Yes, asthma is incurable in the sense that one doesn't get a treatment intervention for however long, and then at the end of that intervention, they no longer have asthma for the rest of their lives. That's what cure is. It's not curable. Okay. So how much symptoms one gets depends on how much exposure they have. It depends on how much control they have, and there are other issues to do with the physiology, like weight gain, like viral infections, that like pregnancy, that can increase or reduce the frequency of asthma symptoms. Also environment. Some people get more asthma when they're in a cold environment or in a dusty environment or in a polluted environment where the air quality is poor. And when they move to a better environment, then they have less symptoms.
So what causes asthma?
So that's a good question. I think to answer that question, I have to introduce a concept of inflammation. Inflammation is difficult to explain to a lay person, but if someone hits you on the face, for instance, you get a painful lump. That is inflammation caused by trauma. Now, this can happen in any part of the body, and it can be caused by many other things besides trauma. It could be caused by allergic reactions. It could be caused by infection. It could be caused by many other different things. Asthma is a propensity or a tendency for specific people who have asthma to react to the environment within the airways in their lungs. And we don't really know why certain people have asthma or not. A lot of it could be allergy driven. Why are you allergic to nuts and someone else isn't? We don't know. It's about an inherent problem that that particular person has that makes them react to the environment in this specific manner inside their airways when they are exposed, and they have this reaction going on, limiting flow of their breathing, hence causing their symptoms.
Okay. Joanne, earlier on when you were making your submissions, you mentioned stigma. That it comes with asthma also has stigma. What have you seen over the years as a nurse yourself? How does that manifest?
Most of us don't believe that we can have asthma, even for mothers, as Dr. Wallis has been speaking about. If you tell a parent that their child is having asthma, she'll tell you that they have never had a history of asthma in the family. So that is one of the stigmas that we have. And then the inhalers, when you don't want to be seen with the inhaler, people think that that's a bad disease. It's not like the way we talk about the diabetes where you get insulin or you have continuous medication. But when you tell somebody that he has asthma, they have a negative connotation about it. So there is a lot of stigma, even among health workers, among us the people, even on how to handle it. And it's very important when one is diagnosed, you need a lot of education and a lot of support, even in terms of taking the inhalers and the medication. Because even people have been saying that there is a lot of addiction in inhalers, which is a myth. There is no addiction in using the inhaler. It's a medication that gives, as Dr. Buika has been talking about, the reducing of the inflammation and even opening the airway. It is important that we keep on educating our population on how to use the medication. And it is important because when you are able to breathe, you are able to continue even doing your own work as before.
Okay.
So it doesn't stop you from being who you are.
All right.
Yes.
Dr. Adil, it's interesting what Joanne is raising, the issue of myths and truths. What are some of the myths you've had and what are the facts?
So, like she mentioned, that they're addictive, and that's completely false. Inhalers are not addictive. You know, you follow up on what Dr. Buika was mentioning earlier, that if you have this condition, it's going to be with you for a duration of time. So what happens is when the standard patient stops the medication, they feel bad 2 to 3 weeks later. Then you take the medication, then you start feeling better, then you stop, and then the same happens again. So then the perception out there is, oh my God, this medicine is actually causing me more harm than good. But the truth is that's not the case. It's like if you have a blood pressure problem, Trevor. You take your blood pressure pill. If you stop taking your pill, your blood pressure starts rising. It has nothing to do with addiction to the tablet. It's just got to do with what you have. It's got to do with you accepting what you have, understanding that you have something that needs to be sorted out, and then you take it from there. I'm also hoping that the audience is also clear that when you're treating asthma, you're going home with 2 inhalers as your mainstay of therapy. So there's a steroid inhaler that you're taking every single day until the doctor decides to lower the dose or stop it. In pediatrics, sometimes you can stop. And then there's the other one Dr. Buika was talking about, which was the preventer. We don't like to use brand names, but there's something called salbutamol. Now, salbutamol is not a steroid. Salbutamol is the medicine where if you start coughing like crazy, you take the salbutamol, again with the spacer device, and then that opens up the pipes, and so now you can start breathing a little bit better. So the salbutamol is not being taken every day. I was talking to one of the members of your audience a few minutes before we started, and this very pleasant lady turned around and says that she's using both the steroid and the salbutamol every single day for the past 3 or 4 weeks. So that's very unsafe, because now her child, and she doesn't know that, and I was afraid to tell her that, but she'll hear, you have to hear it now, is that the heart rate of your child will go up and the blood pressure will go up if you use the salbutamol, and it'll even stop working later on in life. with time over the next month or two.
So what should she do?
So she should stop the salbutamol after 5-6 days, talk to her doctor, her pediatrician, whoever it is, but understand this is actually a very simple disease to look after. The steroid inhaler is every day, and the salbutamol is when you're in trouble. And Trevor, I promise you it's as simple as that. I chose pulmonology as a subspecialty. I always tell my students when I'm teaching at the universities that I did pulmonology because it's easy. So asthma is actually easy. It's the complications that we have. I was talking to you, Trevor, when we were preparing for today's show, and I was saying that this is a lung problem, so you must not drink a syrup.
I hope you're not about to expose my ignorance.
But you know, if I was to talk about media, you'll find some gaping holes in me. The thing is this, antihistamines are not used for asthma. So cough mixtures are not used for asthma. Mucolytics, sorry to throw a medical word at you, is not used for asthma. Yet in Kenya, we're using these things. Cough mixtures should not even be in this country. They are expectorants and mucolytics and mucokinetics and all these crazy medical words that we like to spin and throw out at you guys. But the truth is that, and I have a respected pharmacist on my left, is that there is no cough medicine that works for asthma, and they should never be used. But I'd like to extend this conversation if you can allow me.
Sure.
Cough mixtures should not even be used for any child under the age of 12 years because none of the cough mixtures in the world work. The WHO banned its use in 2003, 2004. The textbooks of pediatrics and pharmacology is what my colleague does, none of them talk about the use of cough mixtures in children, and Dr. Buika is an adult specialist. I think I could also agree even for adult care as well. And this is abuse of drug. Trevor, would you ever put a chemical in your body that God gave you, knowing that there is no proof that it works, only because the doctor wants to support the drug pharma industry and that kind of thing? And this is what we are fighting. They are coming for us. Oh, Dr. Buika, oh, Dr. Waris, oh, write 19 of these drugs and do I need to complete these conversations? But cough mixtures should actually be removed from our market, like they've been removed from the US and Europe. Why is our Kenyan child so different from the one in Netherlands?
So cough syrups don't work, is that what you're saying?
I have in 18 years never, ever prescribed a cough mixture for any child, for any reason. And my children who I look after, with God's grace, are not exactly dropping down dead.
So all this time, Dr. I've had people tell me that it works. So are you trying to say that that is placebo?
It is not. It's worse than placebo. It has side effects that include hallucinations, seizures, reduction in your breath rate, elevation of your heart rate, elevation of your blood pressure. And I tell you, if I go on and on, this audience listening to me right now is going to start freaking out.
Yeah, I'm about to get shocked and walk away from the stage here. So all this time you're saying this shouldn't be given to children below the age of 12 years. And what about adults?
You know, when you're fighting a billion-dollar industry, ... It's a hard one to fight. But I don't want us to lose focus on why we are here. You and I can do a cough mixture conversation at your time and pleasure.
Okay.
But I want us to focus on one statement. Cough mixtures and antihistamines should not be used for asthma. Oral prednisolone and oral salbutamol should not be used for asthma. And I don't know if you can give me 30 more seconds. You asked my colleague, Dr. Buika, what is causing all these things? In pediatrics, it's the viruses. So the parents will tell you that when school starts, the asthma is all over the place up there. Look, the floods in Nairobi and the rest of our beautiful country. So now they're going to be children who are huddled indoors. So next week it's going to be crazy in the land of chest medicine. There's going to be all these children coughing. But also to understand that there's something called allergens. Allergens, Trevor, are something that can trigger an allergy in my body. So we're talking about cat and dog and cockroach and house dust mite, etc. Now the thing is, there's only one statement you need to remember. This doesn't happen to all children and all adults. So just because I say, Trevor, John over here has asthma, it does not mean you kill the cat, chase away the dog, and remove the carpet. You need to talk to your doctor, and you need to do this in a calculated way, so don't harm the whole family. I was talking to Olga, she's part of our audience today, and she had amazing things to talk about mold and the rise of mold in our country. You see, when I was growing up, we were in a townhouse. We could go and run and play. The townhouses are gone. It's now a 20-story building, and this is now being replicated in Kenya big time. So we are washing our clothes indoors. So fungus is growing in our home environment. There are cats and dogs indoors. We're hanging the clothes indoors. We're not opening the windows because we don't want the dust and the noise to come in. So our indoor environment is getting very moldy, and that is causing a lot of problem in our children.
Oh, wow. I think this is the point where I open the floor for questions. How many of you have questions? Raise the show by a show of hands. All right. Where's the microphone? Back there. Everyone has questions. So we'll take 3 questions at a time. Yes. Go ahead. No, just sit. It's fine. We'll pick you from there.
Okay. My name is Kevin.
Yes.
I'm an agronomist, and I run a company called Bush AgriFresh Limited. And where we farm, we normally have adjusted farmers, where I see this trend of the workers spray chemicals, and then after the work, they give them milk. Is there any scientific or medicinal effect of that in relation to asthma?
Okay. So yeah, let's take another question there. So we'll take 2 questions at a time. Yes.
Thank you, Trevor, and thanks for the good panelists you have. My name is Samuel Buru. I'm here for the interest of the informal sector. All this conversation relies on a single thing, from the economic perspective. We need finance to manage the lifestyle from the inheritors and everything. So my question is simple. How can we ensure the economic activities in the informal sector are structured to promote respiratory health, considering the high employment rates in the sector?
Okay.
Thank you.
Thank you. So we'll start with take the question about spraying chemicals and milk. First of all, is there a relationship? Because everybody always say once you spray some pesticides, then you should take milk. It neutralizes it.
Okay.
And any of you can jump in on any of these questions if it's your area of expertise.
Okay, so the 2 issues here. First is that there are specific things that trigger asthma, and chemicals may very well be some of them, but they only trigger asthma in asthmatics. Okay, you can have an adverse reaction to a chemical sprayed in your presence. That is not necessarily an asthmatic reaction. So it irritates your airways, you have spasm of the airways, you cough, and the rest of it. And that is completely different from an asthmatic reaction. And it could be managed in some ways using asthma-type treatments. In addition to that, there are what we call hypersensitivity reactions that happen inside the lungs of people when they are exposed to different chemicals or different organic molecules, and these cause lung damage, and this is a separate thing from asthma. So the short of it is that these chemicals can cause different types of problems, not just to the breathing system, but also to the nervous system. And all this need to be managed in a specific manner, and prevention of exposure of people spraying using personal protective equipment is really important and highly recommended. Now, milk is a fairly nutritious food, as we know, but it has not been shown to treat asthma, to treat bronchospasms, or to prevent hypersensitivity pneumonitis. It's not also been shown to prevent nervous system side effects from these insecticides being sprayed. So if I was that person and I was offered milk, I would probably take it because I like milk, but not in the expectation that it's going to treat or prevent me from problems. There are established treatments and preventative strategies to do that. Now, the second question was about air quality, was it?
Economic activities in MSMEs, area that can be structured to promote respiratory health.
Okay, so air quality is important. It causes many diseases, including cancer, poor air quality. In asthma, there's a concept of occupational asthma. So occupational asthma is asthma that is caused by or worsened by exposures at the workplace. So you are a solderer, you are a mechanic, you work in a factory, you grind flour, you are a florist. Whatever it is that you do, the things that you are exposed to can make you get asthma or worsen your asthma. So we all need to get into the habit of using proper personal protective equipment where we are exposed to such elements, whether they are organic or inorganic molecules that can cause damage to our health. And we're thinking beyond asthma here. So that is really, really important. And we know that industrialization results in poor air quality, and it has caused many, many health problems. And we must embrace industrialization because of the economic benefits we get, but we must do so with due care and due respect for both our own health and our environment.
Okay, let me take two more questions. Yes.
My name is Samuel Gitao, clinician. I would like to ask, are there any plans that the government have to magnify the accessibility to asthma services and improving their quality for better management in the limited resource areas? An example of the inhalers. You say like the inhalers are costly, around 1,000 per inhaler. So are there any plans?
What has been your experience like now that you say you're a clinician, right? You said you're a clinician, right?
Yes.
What have you seen over time? When people come to you, what do they say?
As you said about the stigma itself, it's one of the common causes of the clients not taking the inhalers. So, but once you explain them in the way after nebulizations, mostly that's what you do in case of an asthmatic attack.
Yeah.
Once we do that, we tell them how it happens, and then they're able to carry on and be able to appreciate it. It's a real thing.
Yeah.
And then basically we usually tell them like they have to come back again for review, so that at least you can able to see if they're improving or not.
And on the issue of accessibility, what
Yes.
do they tell you? Is this a hindrance to them? Is it accessible? Is it something they can find easily, or is it too expensive? What do they say?
Okay, basically, I do the pediatric part.
Yeah.
Basically, like an example of the budesonide drug. It's really a little bit of a costly effect, though it lasts at least a month, because you usually use it every day. The cost part of it is a little bit problem for the parents.
Okay.
An example like using the spacer. Okay, many companies are using different kind of spacers, and maintaining of it is becoming a problem.
Okay.
You see, like the one that Dr. Harris has there, it's usually a good one, but others are quite different. You have to deassemble them, put them back together. So when you're telling the clients to buy a spacer or use the right way of using a spacer, it becomes a bit of a challenge.
Okay.
Yeah.
All right. Let's pass the microphone again. There's a question behind you there. Yes. Go ahead.
Hi, my name is Catherine Wamboi. I'm popularly known as Kate Vlogs on YouTube and all other social media platforms. I've been living with asthma for the very many years of my life. I can't remember a time when I was actually playing with other kids. I used to really cough and have this heavy chest. So my mom used to take me to the hospital for the normal treatments where you go to the hospital, get some hydrocortisone injections, aminoflin, all those. And it reached a point where I was taken to this traditional, are they doctors or what? So they gave me these cans of 5-liter jerry cans with, I think traditional medicine. I was supposed to drink that, and then after maybe 2 weeks, I go back to that person to go and vomit what was depicted as the mucus, the sputum. After that did not work, and I was again taken to another person who removed my uvula. it was a very, very painful experience where it was cut because they thought that was what was causing the coughs. Later on, growing up, I went to college, and when I was in college, I was introduced to a lot of steroids that actually damaged my immunity. I got very, very thin limbs and a lot of distribution of fats on my upper body because of a lot of prednisone, a lot of dexamethasone, which were actually working somehow, but obviously for a very, very short period of time. Fast forward, I started doing some kinds of work that required me to do a lot of carrying of heavy luggages. And this is when I decided to go to Google because I got tired of buying inhalers. I used to buy inhalers in wholesale and placing them in my cabinet. I used to have a lot of salbutamol inhalers, those Ventolins. And the reason why I was buying them in bulk is because sometimes I used to go broke and I used to really get sick, so sick that as a single parent, I thought I had to secure myself not to die and leave my son alone. So fast forward again, I decided to Google and look for the best or just a general chest specialist. And Google led me to Kenyatta National Hospital. That is February 2023, last year. So before February 2023, I was living a very, very weird life. I used to sleep with an inhaler. I used to hold the inhaler hapo chini ya pillow. Ikipotea, I just wake up in panic, look for it everywhere. But from February 2023, when I went to Kenyatta National Hospital, Doctors Plaza, I was moving through those other clinics, looking at the door, which one is written something chest, and that is when I went to this particular room. And I saw that this room has a chest specialist. Went in, and I told the doctor that I'm here, I'm tired, I don't want injections, I'm tired of aminophylline, I am tired of those injections that were too much, and I was tired of the medicines that I had carried that day to take to her. I presented prednisolons, I presented all my inhalers on the table. I also had this robe, you know, nilikuwa najipaka sana kwa chest. Yani, my chest was just the menthol feeling kwa chest. Every day I was living like that. That was the last day that I slept a whole night. Yani, that day when I went to visit this chest specialist, a lot was done to me. Getting to see a specialist is very expensive in Kenya. To me, because I'm a small farmer, it's expensive. So I told that doctor specifically that I've used a lot of money I've saved so much to get the consultation fee alone. So I don't want to go home with this condition again. So I want something that is final. I'm tired. I was done spirometry where they tested my lung capacity. I was told to breathe in the tidal volumes, what I used to teach as a former biology teacher in school. All that was done to me. And from there, from the spirometry, they realized I had mild asthma. Actually, it was not even like a very serious asthma. So from that mild asthma, I was given medication. I have never slept with an inhaler from that day. I don't get sick, I don't wheeze, I don't cough. I got healed completely. But one thing I want to tell everybody that is watching me, because thousands of people are watching me from TikTok and all social media platforms, is that it's not like I stopped taking medication. I still use the steroid inhaler that the doctor was talking about every single day, whether I'm feeling okay or I'm not feeling okay. I have to use that particular medication that I was given, and my life changed completely. I'm living a normal life. I can carry luggages, I can run, I can do everything. All right.
Thank you so much for sharing, Catherine. That's a very touching story. And I think we'll take another comment or question there so that we hear. There's a hand that is up.
Thank you.
There's another one here. The microphones are all over. Yes.
Thank you, Trevor. Good evening.
I'll come to this side.
My question is about the environment. Since we have been told by our doctors that the environment that one lives may trigger to one getting asthma. Does that matter after being diagnosed with asthma? Do one have to change the environment, or will you continue being in the environment as you use the inhalers? Since you find most of the times if it's our guardian or our parents, if they are there up country, we bring them to the town and change the environment there.
Remind me your name again?
I'm Dennis.
Dennis, thank you. I think we'll go with that. And Dr. Neil, you can start with this. There's a question from Samuel. Accessibility in limited resource areas. How can that be improved? Yes, go ahead, Dorothy.
I could assist there.
Yeah.
See, when we are having challenges with managing chronic illnesses, that's where now we promote saying, how can we set up an access program? Access program doesn't mean the medicine will become free, but if you can be able to justify the volumes in terms of the number of patients, the patient levels that you can see, and negotiate what we call an access price, a price that is affordable enough, because again, the industry needs to stay in business, so it cannot be free, but it needs to be a reasonable cost that can make business sense, but also pocket friendly. And
now that you're still on the floor, the issue of responsibility for the patient while collecting the asthma medication, what should their focus be on? Because also that price is also a determining factor. They'll come and say that, okay, I may want this one, but I can't afford it. Yeah.
Yes. So I'm working in a public hospital, and our system of being able to avail medicine is looking at the most cost-effective, not cheapest, just what works, and the cost is affordable. So having that in place, having systems we call in our facility, call it a medicine and therapeutics committee, which looks at what products should we have that are recommended in the guidelines. For asthma, we're using a GINA guidelines. So what products are recommended and what can we get in the market that is safe, efficacious, and cost-effective. And because in public sector you have the benefit of large numbers, you can negotiate because of economies of scale. Okay. So that what you avail becomes at a much better price. So now the focus is making sure that it's always available when it's required. And on the broader scale, looking at with the new social health insurance, how can that package make sure that it's going to take care of the treatment, so that when the health policy makers are fixing a figure on the cost, the case-based reimbursement for managing an asthma patient, we look critically how much does it cost to actually have your inhalers, the right ones, for the whole month, so that that is what is the reimbursement model as opposed to just a random figure.
Okay. Yes. Dr. Adil, there was a question from Dennis on the changing of the environment. And first of all, you had mentioned, should children sleep where there's a carpet? I'm going to ask you the most basic questions that I get asked.
The most basic are the most important. Yeah. The child can sleep and the carpet is there. It's not an issue at all.
So it doesn't cause
So as soon as I tell you your child has asthma, it doesn't mean you're throwing those things out of the environment.
Okay.
So we can still live with that. There are two,
can you
things.
Pinpoint exactly what causes asthma in each and every case? Can a parent come to you?
In children, most of the time. Sorry?
This is caused by the pet that you have in the house, or the dust in this particular place, or mold.
I'll restrict my answer to children.
Yes.
For children, 80 to 90% of the time, it's a virus from school that has triggered your asthma. But if you have your inhaled corticosteroid every single day, you'll be fine.
Okay.
Okay. And now we are not going to stop schools. They have to carry on. But even during the COVID pandemic, just to give you an idea, I mean, there was almost nobody in the chest clinics of the various hospitals where I work, because now there were no viruses to trigger the asthma problems that our children were going through. But of course, we have to carry on with life. There are two quick things I just wanted to share, if you can allow me.
Yeah.
This costs about 2,000-3,000 shillings. And we were talking about cost a few minutes ago. But you know, Trevor, that this is also a spacer device. Instead of throwing this into the sea and into our rivers, if you get a hot rod and you make a hole here, that's the size of that, okay? And you stick it in, here's your 2 shilling spacer. You'll get this for free. There's so many people, you're picking this up on the Kenyan street. Second thing, yes, I know that these inhalers are expensive, but I just want us, sometimes we lose focus on how expensive is. You can get a typical good steroid inhaler for around 12 to 1,300 Kenya shillings, depending where you buy. That's steroid inhaler has 120 puffs. Most of the time you're taking 1 puff in a day. So that's going to last you 3 to 4 months. So that's 300 shillings per month. That is free. That is 300 bob per month. And then the salbutamol inhaler, you can get it for between 250 and 450 shillings, but you're only using it when you're in trouble. So if you use your steroid inhaler very well with a spacer device, your cost per month is between 300 to 400 shillings per month. Yes, I know. For some Kenyans, that is going to be an obscene amount. I have no issues with that statement. But sometimes it's good to understand what we're talking about. Our friend who was talking in the audience there about the costs as well. You see, if you're not using your steroid inhaler very well, now you're going to start looking for expensive doctors, doing a spirometry for a couple of thousand shillings, buying the syrups and the antibiotics for 1,000 to 3,000 shillings per set, because we're not using the steroid inhaler. What did the patient say? As soon as she started using the steroid inhaler, every single day, her costs dropped down. So yes, it's expensive, but we're talking to about 300 to 500 shillings per month if used well. That must also be put into perspective. The last thing, this is a very Kenyan thing. It's certain tribes in our country and in Africa that say, kilime imeongeza sana, inabidi tukate. I have my traditional statement to all parents who want to cut the kilimi, which is called the uvula in medicine. I tell parents, listen, your child started coughing 5 months ago, correct. Your child is how old? 2.5 years. Okay, so what was the kilimi doing from the age of 0 to 2? Why are you cutting something that has already been there in existence all this time? Mungu in the sky knows what he's doing. Please don't cut that easily. I beg the Kenyan families listening to me right now, as a respiratory doctor, I'm a doctor who looks after children who are coughing. I have never, and I stand for all my colleagues right now, including the ones on this panel, have ever asked a Kenyan child or adult to cut the kilimi. Please, I beg, don't cut. It is not going to help you.
So this has nothing to do with the kilimi?
Well, it has nothing to do with the kilimi. Okay. It's I hope this doesn't sound racist, but white people and brown people don't have this conversation with me in my office. You get it?
So it's almost like a cultural thing.
Yeah, and it's not every Kenyan tribe. Yeah. I'm not going to name the tribes now. Yeah. You can get into trouble. But it's only a select few tribes in our beautiful land that believe a long kilimi needs to be cut. Long kilimi, there's nothing like long kilimi. It doesn't do anything. Please don't cut it. It's there for a reason. It's there so that when you swallow water, it doesn't come up into your nose and out. Mungu in the sky, put things there for a reason. Okay. You cut, you pay the price.
Interesting. And John, you've been quiet for a while here. John, the people you take care of as a respiratory nurse at the Kenyatta National Hospital, what do you tell them to do when they go home and they have an attack? They're not sure. How do they respond? Do they call someone? How do they tone it down? What do you tell them?
Thank you, Trevor. What I tell them when they go home, they should use their medication rightly, the way they have been taught, because once the patient gets the medication from the pharmacy, comes back and we teach on how to use the inhaler. Yeah. And in adults, we usually do a combined inhaler, which has got both drugs, the long-acting beta-2 agonist, and together with the steroid, which also it works in releasing and also decreasing the inflammation. Mm-hmm. So whenever the patient is having an attack at home and he has a spacer, or even when he is using as a normal inhaler, like the way Dr. Wasilis was doing, you can use it for about 10 times, but every time that you need to do, you don't use you just shake it, then you breathe out fast. As you breathe in, you then inhale for 10 seconds, and then you do it again for continuous. By the time you are reaching the fifth one, at least you have opened. Then you can go and seek for help, because it may be an infection, it may be something else that you can go, but so long as you have been able to breathe. Okay. Even for the mothers, as Dr. Wallis is dealing with the children, we still use them the spacer, and then you do the same way that he has spoken about, that the 10 sprays, but you don't do them that. Okay. You just do one, and then you give for 10 seconds at every interval between 5 to 10 seconds. Okay. And then that way you'll be able to open, and then by that time you can call for the emergency. Okay.
Yes. So the idea is not to panic?
Not panic.
All right.
You always reassure the patient, and the mother. Even sometimes they call us and we reassure them.
Okay.
Yes.
I have to take a quick break here, but I know there's still many questions. By a show of hands, how many of you have questions? Oh my God. Okay, so we'll have to extend a bit of time for the questions, and now we'll take them in fours. All right, we're back in just a bit.